I'm sure you're all experts by now, so it's time to show you a demonstration where we can solve the problem together. Here we have a 60-year-old patient who had mitral valve implantation 19 years ago. My question to you, what kind of a prosthesis is it? I do not know myself, so let's see if we can solve this problem together. Mechanical or biological? Well, I think it's quite apparent that there's a lot of shadowing, so it must be a mechanical valve. If you're not sure, another trick, take a look at the 4-chamber view. Just place the continuous wave Doppler signal. If you have these sharp echoes right at the beginning and at the end of the inflow signal, then it is a mechanical prosthesis. So we solved this question. Next question, is it a bileaflet prosthesis or is it a tilting disc? Difficult to say from this view. Also very difficult to say actually from an apical view. What you can do is you can turn the transducer and rotate the transducer if you can until you maybe see the two tilting discs. Sometimes it's possible to get an orientation where it's possible to distinguish the two types of prosthesis. In her case, an atypical view helped us out, a view which is almost a parasternal short axis view. And in this view, here you can nicely see we have two discs which open V-shaped. So very nice to see that we have a tilting disc, or we have a bileaflet prosthesis. I'll show you here from the image that I captured previously. I think looking at this image, it's quite clear. So almost a short axis view. We have one disc here and one disc here, or one leaflet here and the other leaflet there. So bileaflet mechanical prosthesis. It's fairly easy to recognize a biological mitral valve. First of all, you do not have as many artifacts within the left atrium. Second of all, you have biological tissue here and the typical motion of a leaflet which resembles that of an aortic valve. And third, you can see the struts. Usually you have to rotate the transducer a bit and then you can see at least two struts within the image. Here's another example. This time the valve is a bit more difficult to assess simply because the valve is calcified and more echogenic. And here you can see that with the help of color Doppler we can see turbulent inflow and also some degree of mitral regurgitation. But we'll talk about those issues later in the chapter. So this completes the prosthetic mitral valve. Now we'll turn to the aortic valve and see how echo can help us to determine if aortic prosthetic valves function normally or not. Well, in principle, it's very similar to the mitral valve. We look at the morphology, the gradients, and the color Doppler signal. This is a patient with a normal bioprosthetic aortic valve. The patient also has a mitral valve, also bioprosthesis, but now let's first take a look at the aortic valve and let's look at the features of bioprosthetic valves. The first thing that you will recognize is that we do see leaflet opening here, and we do not have as many artifacts as we would in a mechanical prosthesis. We also see the rim of the prosthesis here, but in reality, the prosthesis is better visible in a short axis view. We can first of all see the ring here if we tilt more towards the aorta, and also the struts if we tilt more towards the LVOT. So this is one strut, this is the other strut, and this is the third strut. And here in between we have the three leaflets of the valve. What is also helpful is the M mode, because if you perform an M mode, you would nicely see the typical pattern you would actually also see in a normal aortic valve with the box opening, and we do not have the artifacts that would be apparent in patients who have a mechanical prosthesis. One other thing that is helpful is if you look at the continuous wave Doppler spectrum across the bioprosthesis. We'll do this here. Okay, continuous wave Doppler spectrum. What we do not have is we do not have the very prominent closure, opening and closure artifacts that we would have in a mechanical prosthesis. So normal pattern, similar to the pattern you would have in a normal aortic valve or actually in an aortic stenosis patient. So you see, if we use a multimodality approach with the help of M-mode, 2D, and Doppler, we can distinguish and determine which type of valve a patient has. Now that we saw a biological valve, we'll turn to a mechanical valve and see how that shows up in an echocardiogram. This is a patient who received a mechanical aortic valve 11 years ago because he had aortic stenosis. It's a bileaflet mechanical valve, a Techna valve, 23 millimeters. Now let's take a look at what we see in the two-dimensional echo. The first thing we immediately recognize is that we do not have a normal aortic valve, but we have a lot of echoes and echogenicity and artifacts located here in the aortic valve. If we look at the valve in a short axis view, we can actually see the ring of the prosthesis. Just have to tilt up and down a bit. The ring is around here. And then you see the two leaflets of the prosthetic valve here in between. Indicative of a mechanical valve is the fact that if you turn on the M mode, you have a lot of artifacts located here along the left atrium, which are caused by the leaflets. Another way of looking at the aortic valve is, of course, from an apical view. We'll do that. And we use the 5-chamber view. We bring the patient more on the back, and you will immediately recognize that there are a lot of artifacts and mechanical material located in the aortic valve. So what you see nicely here is you see the opening and closure of the valve. However, in this view, it is sometimes very difficult to determine if it's a bileaflet valve or a tilting disc. Now, if we look at color, we'll try to figure out if the patient has regurgitation or not. And to do that, we tilt the transducer up and down to scan the valve, and also turn the transducer a bit to look at all the different portions of the valve. We do not see regurgitation here. We can also go to the apical long axis view to see if we have regurgitation. Again, we do not see regurgitation. And then we can also, to make sure that there is no regurgitation, go to the peristernal views. Take a look at the long axis view. Scan the valve by moving the transducer in both directions. And then also use the short axis view, because in this view it is often possible to differentiate between a valvular and a paravalvular regurgitant leak, simply because we can see if the origin of regurgitation is inside or outside the valve. So scanning the valve up and down, we can see that this is a completely normal mechanical valve which does not have pathological regurgitation. In patients who underwent valve replacement, you will very frequently also find other things, such as mobile structures which belong to the subvalvular apparatus, cavitations, and abnormal septal motion. This is such an example of a patient with severely abnormal septal motion. Here's a beautiful example of so-called cavitations. Those are those bright little speckles which you see in the left ventricle, which seem to arise from the region of the mechanical prosthetic valve. Cavitations probably represent vaporized blood, which is related to fluid dynamics across mechanical valves, such as pressure recovery. It has actually been proposed that such cavitations can cause high-speed microliquid jets, which are even able to damage the prosthetic valve. In clinical practice, however, cavitations are of no relevance. We do not see more or less destruction of prosthetic valves if we have cavitations. However, there seems to be some association, at least, between hemolysis and the presence of prominent cavitations. Here's an example again of cavitations, but this time caused by an aortic prosthetic valve. Another fairly frequent finding in patients following mitral valve replacement is the presence of mobile structures which belong to the subvalvular apparatus. Residual subvalvular structures. Remember, the surgeon always tries to preserve as much of the mitral valve as possible. Sometimes we'll even find such tissue in close proximity to the prosthetic valve itself. And such tissue and such structures can actually hinder the opening or closing motion of the prosthesis. We saw this patient here on the bottom right already. It's the patient with the abnormal septal motion. But why do these patients actually have such an abnormal motion following replacement? It's a very frequent finding, as a matter of fact. Well, one thing is clear. It's not caused by ischemia. It is assumed that it is related to the opening of the pericardial sac. Does it have any clinical relevance? Well, honestly, I don't know, and there's not very much literature out there. But my guess would be, especially in the light of new findings in patients who have dyssynchrony for other causes, that it probably does affect the left ventricular function, at least in the long run in these patients. So my guess would be probably yes, but probably not to a very severe extent. But this is just my unproven opinion. Without any doubt, the biggest problem in the evaluation of mechanical prosthetic valves is that we have shadowing and artifacts. Here's such an example where you can clearly see that large parts of the left atrium are just not visible. And this is a particular problem if you're looking for regurgitation, endocarditis, and thrombi. All of these pathologies are located distal to the prosthetic valve, at least in a 4-chamber view. So transthoracic echocardiography is actually not very good if you want to evaluate mechanical valves. But it's usually sufficient. But if you do have any doubts as to the function of such a valve, it's always good to consider TE. Because with TE, we're taking a look at the mechanical valve from the other side, from the left atrium. So we don't have any shadowing here. But as a negative aspect, we have shadowing of the left ventricle. But in general, TE and transthoracic echocardiography are complementary in the evaluation of mechanical valves. Here is such an example of a TE study where we can now nicely see the left atrium and the atrial vicinity of the prosthetic valve. The shadows are now in the left ventricle. What about shadowing of mechanical aortic valves? Well, if you're looking for regurgitation in a 5-chamber view, it's not really a problem because we have the shadow right here and we're expecting regurgitation right here. It is, however, a problem if you're looking at the parasternal long axis view because the anterior parts of the prosthetic valve will cast a shadow on the remaining parts of the prosthetic valve, and thereby it's very difficult to really see the origin of jets and sometimes even to detect regurgitation. To demonstrate that, here's an example. Parasternal long axis view, mechanical prosthesis. Here we have the shadow, and we're not able to see the leaflets and the motion of the leaflets. We cannot see the origin of the jet, the flow convergence zone. To determine the gradients across a prosthetic aortic valve, we do not do anything different than we would also do if we quantify aortic stenosis. So we would start from a 5-chamber view, try to optimize the image in such a way that we are parallel to the ultrasound beam, and then we use the continuous wave Doppler and place the sample volume exactly in the valve. And what we will get is we would get a signal which looks like this. The difference compared to a classic aortic stenosis signal is that we have very sharp echoes at the beginning and at the end. So these signals are caused by the opening and closure of the prosthetic valve and are also indicative that this must be a mechanical valve. So if we quantify the gradients, we would simply trace this curve. Oops. Let me just do this again. And we just have to watch out that we really get the outline of the curve. And then we get a maximum velocity of 3.7, which corresponds to a gradient of 56 and a mean gradient of 28 millimeter mercury. And so if you have these values, you would then compare them to the normal values for this type of prosthesis, the Tecna bi-leaflet valve, and to the size of the valve, which is 23 millimeters. So quantifying the gradients over a prosthetic valve is not very difficult. However, in some patients, you don't get such good image quality as I showed you in this demonstration. In such patients, it is sometimes advisable to use a right parasternal approach with a Doppler probe, with a pencil probe, similar as you would use it in the setting of aortic stenosis. And now we'll take a look at a mechanical mitral valve and see how we can use continuous wave Doppler to test if the function is normal. As you will see, we don't do anything different as we would in the setting of mitral stenosis. So here again is our 60-year-old patient with a mechanical mitral valve. And now I want to show you how I would use the continuous wave Doppler to evaluate the valve. The first thing I do is I place the sample volume here right inside the valve and optimize the focus point, bring down the zero line and maybe increase the velocity here, and then I freeze the image to get a very nice signal. This is the typical signal of a patient who is not in sinus rhythm. We don't have an A wave, but that does not really matter for our evaluation. We look at two things. The first thing is we try to see what the mean gradients are. To do that, I just trace the curve. Okay. I get a mean gradient of 6 millimeters mercury. And then the second thing I do is I look at the maximum velocity, which is not as important, 2.2. And then I perform a pressure half-time measurement. So the pressure half-time measurement is 63, so also a completely normal valve, no signs of obstruction. So it's not very difficult to assess the function of a mechanical mitral valve with the help of continuous wave Doppler, at least not in the most cases. And it's very similar, as you saw, to mitral stenosis. The only difference is that if you perform a pressure half-time measurement, you cannot translate that into an orifice area as we would in mitral stenosis. In the report, we just put the number or the value for the pressure half-time. I would recommend that you educate your referring physicians not only to report on which type of prosthetic valve a patient has, but also which size. Both determine how high the gradients across the valve are. Here's a nice example for the St. Jude bileaflet aortic valve, where you can see that the smaller the valve is, the higher the mean gradient is. Of course, there are certain variations which are caused by differences in cardiac output, but in general you can see that there is a dependence on the size of the prosthetic valve. It's also important to know these cutoff values because without them you cannot determine if the patient has a pathology, for example, valvular obstruction. This diagram just confirms what I said previously, that there is also flow dependence. In other words, if you have a specific size of prosthetic valve, and if you increase the flow, you will also increase the gradients. So both of these factors have to be considered when you evaluate patients with mechanical but also biological valves. We put together numerous tables of the most frequently used prosthetic valves and their normal gradients. You will find these again in your fact sheet. For those of you out there who really want to dig deep into the evaluation of prosthetic valves, here's also a formula with which you can calculate the effective orifice area in prosthetic valves. Usually you do not need it, but it can be handy if you want to determine what the influence of stroke volume on the gradients, for example, is. One thing which you should keep in mind is that the geometric orifice area is not the same thing or does not correlate necessarily with the effective orifice area. This is nicely shown in the study from this data by Claudio Muneretto, who showed that, for example, we have fairly large variations both in biological and mechanical valves. One other pitfall in the evaluation of patients with prosthetic valves that I want to mention is the so-called pressure recovery phenomenon. What is pressure recovery? Well, it's a localized pressure drop which occurs right close behind the prosthetic valve, usually in patients who have small aortic roots, below 30 millimeters, and small bileaflet valves, and where we have high flow. And this pressure drop exaggerates the gradients across the prosthetic valve and could make us believe that there's some form of obstruction. Just as everybody wears clothes that fit, we also need a prosthetic valve that fits our body surface area. So if a too small valve was implanted, we have a prosthesis mismatch. A prosthesis mismatch is defined as an indexed effective orifice area below 0.85 square centimeters per square meters of body surface area. But why does a surgeon implant the too small valve in the first place? Well, it might be technically difficult, especially in the setting of a calcified aortic annulus. The fact is that if we have a too small valve, we have elevated gradients across the valve, and we have an increase in late mortality, especially in the setting of left ventricular dysfunction. This is nicely shown in a diagram which was published 2009 in the Journal of American College of Cardiology, where you can see that patients who have a severe prosthesis mismatch have a higher mortality. But enough of theory and diagrams and numbers. Let's go back to actual echo images. Here are just a few examples of typical flow patterns across the prosthetic valve or across valves, both from a transesophageal approach. Here you can see a patient with a mitral valve prosthesis who has a normal regurgitant flow, which arises from the rim of the valve. Here, another valve, a bileaflet valve again, also a transesophageal approach, where you can see the three different jets, two from the rim and one from the center between the two leaflets. A mechanical aortic valve. Actually, I don't even know which type of valve this is, but again, certainly only mild, normal physiologic regurgitant flow. And here, a three-chamber view, also with normal flow of a mechanical aortic valve. One last statement to the question of how often should we actually perform echocardiography in patients who have prosthetic valves. Well, I think if it is a normal valve and everything went fine with the operation and ventricular function is normal, it's sufficient if you check the patient every year or every 2 years. If the patient, however, has a problem, the intervals have to be much shorter. Which problems can occur? This will be the topic of the next chapter.